Hello everyone, I'm Dr. Farooq Rathore from Pakistan, and today I'm going to talk about how long COVID-19 is a window of opportunity for rehabilitation professionals. What started as a viral illness from Wuhan, China in December 2019 rapidly spread to involve more than 200 countries around the globe, resulting in an unprecedented pandemic. After more than 2 years, the World Health Organization estimates that more than 600 million people were affected all around the globe, resulting in more than 6 million deaths. The good news is that more than 400 million people have recovered. But we need to stop here and ask the question, have they actually recovered? There is a large subset of people who have actually negative COVID-19 test, whose inflammatory markers might be normal, and they might not have any medical symptoms at all. But these are the people who are not well. And these are the people having symptoms that cannot be explained. These are the people having a poor quality of life. And these are the kind of people that even many healthcare professionals dismiss. And this is the group known as long COVID-19. Currently in the literature, long COVID-19 is being discussed by different names. It could be chronic COVID, post-acute sequelae of SARS-CoV-2 infection or PASC, post-COVID syndrome, long-term COVID, persistent COVID-19 syndrome, or long haulers. But all of them mean the same thing, people having long COVID-19. The World Health Organization has given a definition of long COVID, which says that it is a condition which occurs in an individual with a history of probable or confirmed COVID-19 infection, usually 3 months from the onset of COVID-19, with symptoms that last for at least 2 months and cannot be explained by an alternative diagnosis. Sorry. There are many ways in which long COVID-19 can present, and I would like to discuss this systematic review that was published in Nature in August 21. There are more than 50 presenting features of long COVID-19 that have been identified, but the most common are tiredness, dyspnea, fatigue, and cognitive dysfunction known as brain fogginess. It also includes headache, persistent loss of smell or taste, which makes your life miserable, cough, depression, and low-grade fever, which cannot be explained by any other alternative medical diagnosis, palpitation, dizziness, a feeling of muscle pain, joint pains, myalgia, polyarthralgia, and muscle soreness, which ultimately results in compromised mobility, socialization, and reintegration back into life. Now, long COVID-19 is not as problematic as an acute COVID-19 infection, which can actually lead a patient to a ventilator. But the issue with long COVID-19 is actually a poor quality of life, a compromised mobility, and a reduced chance of reintegration back into the life as an active earning member. Unfortunately, when long COVID-19 was detected more than 1 year back, initially it was not by the healthcare professionals. It was by the lay public or the media which highlighted this kind of issue that was being faced by people with confirmed infection of COVID-19. And as you can see, it started off in New Atlantic Journal, Newsweek, and there were people who were actually saying that there's something coming up that cannot be explained by an alternative diagnosis. The Atlantic said that COVID-19 can last for several months, and there were many other reports that were published in the lay press. I'll quickly share two narratives by people who had long COVID-19. So the first one is Fiona, a US writer. She says, "It almost feels like I have been hit by a truck at 4 p.m. each day." Now, 4 p.m. is actually the middle of the day. So many of us who are professionals, who are doing work and job and other things, so 4 p.m. is just middle of the day where you have a half of the day still remaining and you have to do a lot many things. So imagine if you don't have energy at 4 p.m. how you are going to drag yourself into the evening and into the night. The other narrative is from Dr. Paul Garner, who is the professor of infectious disease at the Liverpool School of Tropical Medicine. And he says, "I have had dengue, I have had malaria. I have never been as ill as this. And it's really, really frightening because it's so unpredictable. It's the worst illness I have ever had. I am still dealing with exhaustion." So again, exhaustion, fatigue, myalgia, one of the hallmarks of long COVID-19. Dr. Robert Glater, an emergency physician from the USA, says, "We really have to pay attention now that COVID-19 has created these long haulers. People who go through this for months get really anxious and frustrated and depressed, and they do not know how long they can keep fighting." So long COVID is actually an entity that needs to be identified, and then we need to manage that. There was an excellent paper that was published in eClinical Medicine, and it was actually an online survey of more than 3,000 respondents from 56 countries, including SAARC countries, Bangladesh, India, and Pakistan, and in which they documented that in patients with a mild or moderate degree of COVID-19, the recovery time can exceed 35 weeks, which means more than 9 months. And patients with long COVID-19, they report prolonged multi-system involvement and significant disability, as I've just discussed earlier. And by 7 months, many patients were even not recovered, and mainly from systematic and neurological cognitive symptoms, the brain fogginess that I just mentioned. And they have not returned to their previous level of functioning. That is, they had problem with reintegration back into the community. So some consideration for long COVID that we need to understand as healthcare professionals. The first and the most important is, please remember, there is no correlation between the severity of COVID-19 and the symptom of long COVID, which means that even patients who have mild COVID-19 can actually end up as long haulers or people having long COVID-19 symptoms. And it is possible that someone was on ventilator, but he or she made such a good recovery that there were no sign symptom of long COVID-19 in the long term. So there's no correlation between severity and symptom. So even if a patient who had a mild COVID-19 disease comes to you, please listen to the patient. He actually might be having a long COVID-19. The other thing is young people can also have long COVID-19. We have seen this pandemic. It does not discriminate, between nations, between religions, and between ages. So yes, it mostly affects the elderly and people with comorbidities, but it can actually affect the younger people as well. So if next time a young person who comes to you and says that I have recovered from my acute COVID-19 illness, but I still have cognitive dysfunction, I still have aches, pain, and myalgias, and all of my lab reports are normal, please understand that young people can also have long COVID-19. It is more commonly reported in females, and unfortunately, at least in the developing countries like India, Pakistan, Bangladesh, and the SAARC countries, there's the issue of medical sexism, in which we try to negate the symptoms that a woman will tell you. So you would say, oh, as we say in Urdu, आपको तो ये तकलीफें रहती हैं, बस आपको तो ये दर्दें हैं, ये आपके दिमाग में है. No, it's not like that. It is actually a problem that needs to be understood, that needs to be explained, and that needs to be addressed. So please do not, have this kind of medical sexism in which you do not regard the symptom of a female and try to prioritize a symptom of a male over a woman. And unfortunately, this long COVID-19 is still unrecognized. It is neglected, it is ignored, and it is even dismissed by many healthcare professionals. The eye cannot see what the mind doesn't know. So if you are not yourself clear about what is long COVID-19 and how it can play havoc with the life of a patient, you are going to dismiss is that ये सब आपके दिमाग में है. So it is not like that. It is an entity that has been recognized both by World Health Organization and other international organizations working in healthcare sector. Now coming to the part that why is COVID-19 a global tragedy, a global pandemic, a window of opportunity for rehabilitation professionals all around the globe, but specifically in developing countries like SAARC region. For this, I'm going to take you back into history, and I'm going to take you back in October 2005, Pakistan. So back in October 2005, we had one of the worst natural disasters in the history of the country. We were struck by a major earthquake which resulted in a lot of disability, death, and it left in its wake tales of sorrow, misery, and tears. Unfortunately, Pakistan was not prepared for this kind of calamity, and once we had patients with long bone fractures, nerve injuries, and specifically amputation and spinal cord injury, sometimes we even did not have beds. And we had to manage these kind of patients in open areas and make shift tents. At that time, rehabilitation sciences in general and rehabilitation medicine in particular had very little recognition in Pakistan. And suddenly, we had a huge number of traumatic spinal cord injuries and amputation who do not only require an acute care, they also require a long-term integrated rehab plan. And we had no integrated plans for care of acute surgical management for most of these patients. There were very few and poorly equipped rehabilitation facilities available who could obviously do not take the burden of all these hundreds and thousands of patients. So what happened? The rehabilitation team The rehabilitation medicine doctors, physicians, physical therapists, occupational therapists, and orthotists, they rose to the challenge. We, as a team, provided services and we documented our experience of providing services in these challenging times. And we shared data in form of presentations, in form of articles, in form of papers, in form of writing in lay press, in form of educating others. And once we started doing that, people actually started coming from all around the globe and they started helping us out. They helped us with spinal cord injuries, they helped us with traumatic amputation, long bone fractures, and other major disabilities. So what was the outcome for rehabilitation sciences? So out of this tragedy, we had very positive outcomes. Number one, we had great recognition for rehabilitation sciences, which was not there for many decades. Number one. Number two, we had a development of an integrated models where different rehabilitation professionals, the physician, physical therapist, occupational therapist, and other members of a standard multidisciplinary team, they started working together. And the third thing was that it increased the educational output of our rehabilitation professionals. And they were able to document their experiences, write articles, and make the world realize that there's a window of opportunity even when a disaster strikes. So with this background, how you and me can make a difference in this pandemic, which is a global issue and a global problem. The first thing is we need to understand in the middle of difficulty lies opportunity, and there is always light at the end of the tunnel. Yes, we lost many people. Yes, there were people who had to face a prolonged misery. Some went on ventilator for weeks and in some cases even for 2 to 3 months. But the point is we have to rise to the challenge. And what we can do? The first thing is rehabilitation professionals have to be proactive. Now it depends on where you're working, but unfortunately, at least in the acute phase of COVID-19, there was very little input of rehabilitation professionals, and the focus was on acute care medical team, the pulmonologist and the people who are infectious disease specialist. But you have to be proactive. The eye cannot see what the mind doesn't know. Sometimes our colleagues working in other specialties do not know what is the value of providing early integrated rehabilitation services to these patients who are having acute severe COVID-19. So you have to be proactive. You have to go to your colleague in infectious disease, in pulmonology, in internal medicine, and you have to tell them how integrating early rehabilitation services, physical therapy, mobility, exercises, and rehab consultation can make a positive difference in the long-term outcome of these patients with COVID-19. Number two, you have to educate people. You have to educate them in different formats. You can have these kind of online webinars, seminars, small lectures. You can write and you can actually document your experiences. For example, look at this. I love this article. So this is a COVID-19 rehabilitation prospective surveillance model which is used by physical therapists. So we know whenever like there's a wave of COVID-19, there are certain restrictions, which means that people do not get the essential rehabilitation services that they should be getting. So you should have your own models depending on your own local context, and you can still provide rehabilitation services and you can come up with these models, and please try to share these models with others so others can get inspired, they can get ideas, and they can also provide the same level of service that was being provided pre-COVID. And look at this. So this is a model which tells you, I mean, this is a whole model, and I'm going to sort of break it down for you for easy understanding. So whenever patient comes with a scheduled physical therapy, you do a rapid screening. If there is a symptom for COVID-19, you have to make a certain referral. And if there are no COVID-19 symptom recently, then there's a checklist that you have to follow. And once you do that, then you do certain kind of general assessment. You take vital signs, you auscultate, you see the body composition, and you document the quality of life at the start. And then there are certain parameters that you have to see. And after that, you go for the specific assessment and treatment orientation. And this is a model which tells you if there's a cardiorespiratory issue, what kind of guidelines or what kind of service you can offer them. If it's a neuromuscular, what you need to do. If it's a mental health issue, the brain fogginess or cognitive dysfunction, what you need to do. So wherever you are based, depending on your own hospital, the team that you have, expertise that you have, you can make up your own models of providing rehabilitation services, both to the acute and the long-term COVID-19 patients. The third thing that you should be doing is actually document your experiences. Now, each one of us who is working with COVID-19 for more than 2 years has a unique experience of working with COVID-19 patient, both in the acute phase and the long-term phase. It's a unique experience. Just because an experience is being shared by by our colleagues in Europe, Northern America, Canada, Australia, does not mean that it's going to be the same experience for a person based in Southeast Asia. It's going to be different because yes, we are different. Our culture is different, our healthcare system is different, the way we interact with patient is different, and our patients are different as well. That's why you need to document your experiences and you have to generate evidence, because please remember, things are clear about COVID-19, but things are still not in black and white regarding long COVID-19. There are questions that need to be answered. There are issues that need to be settled, and probably rehabilitation professionals can address many of these issues. And that's why every contribution that you make from any part of the world would actually matter and help complete the bigger piece of the puzzle. So what you can write? You can write database articles. For example, epidemiology and clinical features of long COVID-19. So you start documenting the patient who are coming to your clinic and having symptoms of long COVID-19. You do simple epidemiological and clinical profile studies. Or maybe you want to document the role of different rehabilitation interventions. You take a group of patients, you take their demographic data, and at the baseline you start giving them certain kind of rehabilitation intervention, and then you start documenting them, and then you redocument and reassess them after every 4 weeks or maybe a month or whatever is convenient for you, and then you publish that data-based article. You should also be doing research on outcomes, and the most important is please do research on the long-term follow-up outcomes of long COVID-19, because unfortunately for many of these people, they are complaining that doctors abandon us after managing us in the acute phase, but we have issues that are long-term. So who is going to take care of our long-term needs? And I would say it is the rehabilitation professionals. Apart from that, if you don't have hardcore data to support your articles, you can write anything and in any format. And if you go and research the literature, you would see that people have actually shared their experience of working with both acute COVID-19 and non-COVID-19 rehabilitation in form of many things. It could be a simple letter to the editor. It could be a perspective of working in a developing country with an underdeveloped healthcare system. It could be a personal view of your own point of view, that I thought long COVID-19 rehabilitation was a challenge for me because of these reasons. And this was my experience, which I want to share. Then you can publish observations, editorials, you can comment on already published articles on long COVID-19 rehabilitation and give your own perspectives. Then you can write mini reviews, special communication, and brief report. So there are many formats in which you can share your experience of working and providing rehabilitation services to patients with long COVID-19 symptoms. So in the end, I would give you a call for action, and I'll give you a plan which you follow. If you integrate, I'm pretty sure you are going to do well both for your patient, professionally, and you're going to educate the world about the role of rehabilitation intervention in long COVID-19. First of all, please educate yourself. The eye cannot see what the mind doesn't know. You need to be very clear what is long COVID-19, what are the different variants, how do you make a diagnosis of long COVID-19, and what are the symptoms with which the patient with long COVID-19 will present. And then you have to understand how it's going to adversely impact the patient's life. It's not going to sort of kill the patient, but it's definitely going to hamper the reintegration back into the society. Then you have to educate others. You have to educate the general public, you have to educate the healthcare professionals, and you have to educate the physician. And you can do that by lectures, both in person, online, workshop, and training sessions like this one. Then you have to provide service. So then the first part is you start recognizing these patients and you provide them adequate targeted rehabilitation services that can improve their mobility and quality of life. If possible, if you are in a leadership position, please at least think of establishing specialized long COVID-19 rehabilitation clinics in your department. And whatever you do, please document the work and share it with the wider world so that they know what positive difference rehabilitation professionals can make even in an adversity like COVID-19 pandemic. So the take home message is this stuff of long COVID-19 is real. People are ill. Doctors need to stop diagnosing this as anxiety. We have messed up before. Let's not do it again with long-term COVID-19 illness. I thank you all for your listening. If there are any questions, I'll be glad to answer them. Have a great day, everyone.